Good morning, everyone. Today's topic is patient safety goals. So, patient safety is one of the important uh, priority in all the healthcare settings. So, let's see what are the things that comes under patient safety. What is patient safety? Patient safety mainly consists of safety culture. So, let's see what is safety culture. Mainly, safety culture is a product of individual and group. It comprises of values, attitude, principles, perceptions, competencies, and patterns of behavior that determine the commitment to and the style and proficiency of organizations' health and safety management of care. Patient safety and its culture. Mainly, patient safety and culture are the beliefs, values, norms shared by healthcare staff. So, patient safety culture it will be rewarded, supported, expected, and accepted. So, it can exist in multiple levels, mainly in the unit level, departmental level, hospital level, and system as a whole. So, any improvement efforts focused on elementary medical error. That means the failure of a planned action to be completed as intended. It can be a medical error. So, is fundamental care itself. That means fundamental care itself is first no harm. Basic dimension of care performance, the underlying reason for risk management, infection control, and environmental management program. So, safety competencies framework domains. There are mainly six domains, and they are patient safety culture, teamwork, communication, safety risk and quality improvement, optimize human and system factors, recognize, respond, and disclose patient safety incidents. Why patient safety? In the 1999, according to the Institute of Medicine, has published a book, and in that book they have clearly mentioned the error is human, which breaks the silence that has surrounded medical errors and their consequence, but not by pointing fingers at caring healthcare professionals who make honest mistakes. After all, the error is human. Instead, this book sets forth a national agenda with state and local implications for reducing medical errors and improving patient safety through the design of a safer healthcare system. So the experts estimate that as many as 98,000 people die in any given year from medical error itself. So that occurs in hospitals. That's more than die from aeroplanes, motor vehicle accidents, breast cancer, or AIDS. So four causes that receive far more public attention. So according to this report in 2001, according to the Institute of Medicine, crossing the quality of chasm makes an urgent call for fundamental change to close the quality gaps. This book recommends a sweeping redesign of the healthcare system and provides overarching principles for specific direction for policymakers, healthcare workers, clinicians, regulators, purchasers, and others. So there are six aims of improvement. So it mainly stresses on six main aims of improvement. That is safety, timeliness, effectiveness, efficiency, equity, and patient centered. The first dimension is safety. So avoid injuries to patients from the care that is intended to help them. You might think this goes without saying, but the reality is even in developed nation, as many as 1 in 10 hospitals patient is armed while receiving care. So what is the solution? Solution, we all know that patient safety is at most priority. We need to work as a team to take care of the patient safety. Second dimension is timeliness. So reduce the waits and sometimes harmful delays for patients and providers. Any treatment is delayed, it can always have a harmful effect on the patient health. So delays hurt both patients and caregivers. According to data from the Centers of Disease Control and Prevention, the average time that US patient wait in the emergency department to see a doctor is 1 hour. The solution here, we need to work as a team from the reception to the nursing and to the doctors, physiotherapists. We all have to work as a team to reduce the waiting time to our patients and attend to them as much as early we can. So third dimension is effectiveness. Provide the appropriate levels of services based on scientific knowledge. So the problem here is the care should be based on evidence, the best scientific knowledge about what is likely to happen, help them or harm a patient. Healthcare should match science with neither overuse nor underuse of the best available techniques. Yet, too often, patients either don't get the full array of recommended care or receive unnecessary medications, procedures, technologies, or services. The solution is we need to clearly define the goals when the patient is with us. What kind of treatment plan is the patient supposed to receive, and the designing a individual patient care plan is always helpful for us to underuse or overuse the treatment. The fourth dimension is efficiency. Avoid waste and including waste of time, equipment, supplies, ideas, and energy. Here the problem is too often the healthcare we see equipment, supplies, ideas, and energy go to waste. A 2012 study by Dr. Donald Berwick and Rand Corporation analyst Andrew D. Hackworth estimated at least 20% of US health spending goes towards six categories of waste: failure of care delivery, failure of care coordination, over treatment, administrative complexity, pricing failures, or fraud and abuse. So the solution is using the resources in an appropriate way will always help us to avoid wastage. Fifth dimension is equity. Care should vary in quality because of personal characteristics. Care shouldn't be vary in quality because of personal characteristics. The problem here is more and more studies show that quality of care varies based on the patient's personal characteristics such as gender, ethnicity, geographic locations, physical status, and socioeconomic status. The implication can be dramatic. So the solution here is when the patient knocks at the door to any hospital or healthcare facility, we need to provide them a quality care, and our care should never be compromised with considering the based on the characteristics of the nature of the patient. So we need to always have a equity in our care. So the fifth dimension is equity. So equality, equity, and justice. The assumption is that everyone benefits from the same supports. This is equal treatment. Everyone gets the support they need. This is the concept of affirmative action, thus productivity producing equity. All three can see the game without supports or accommodations because the cause of the inequity was addressed. The systemic barrier has been removed. So it's always whenever we deliver care to our patient, we must always consider the equality, equity, and justice. Sixth dimension is patient-centered care. Provide care that is respectful of and responsive to individual patients. The problem is helping people implies that healthcare professionals are going to listen to them and address their needs. Yet it is interesting how frequently patients complain about the lack of customer involvement and service in the healthcare industry. Studies of physician patient interaction show physicians listen to patients' concerns for an average of only about 20 seconds before interrupting. That means always patient centered care can also improve the good patient outcomes as there is the more attention and care is given to the patient and his needs are always listened and taken care of. Mainly patient centered care, we know that this dimension has more other areas like to focus on the access to care, patient preferences, information and education, coordination, emotional support, physical comfort, family and friends, continuity and transition. So all these are together going to support the patient-centered care. Swiss cheese model. To be most effective, multiple levels of barriers should be established. Reason argues that most organizations have established four separate levels of barriers. The four levels of barriers are sequential in nature, meaning that those levels at the top affect the levels below. Within each level, failures can cause holes in the safety barriers. These failures can either be active, those occurring immediately prior to an accident and directly impacting events, or latent, those removed temporarily from the events and not exhibiting a direct impact. But what exactly are these holes in the safety barriers and how can they be systematically identified? Mainly, we can see here some holes due to active failures, hazards. Other holes are due to latent conditions. So the mainly here we can see hand washing, cleaning and disinfecting, social distancing, and using of mask. So all this can, if it is not done in an appropriate way, all these measures are failed, then we are introducing infections to our patients. So in a way we are harming them than helping them. So one action of disinfection or hand washing is related to the other. Social distancing, wearing mask, all these are contributing to prevent infection. How to assure patient safety? According to World Health Organization, Joint Commission International and the Joint Commission JCI works to improve the patient safety and quality of healthcare in the international community by offering education, publications, advisory services, and international accreditation and certification in more than 100 countries. So JCI partners with hospitals, clinics, and academic medical centers, healthcare systems and agencies, government ministries, and international advocates to promote rigorous standards of care and to provide solutions for achieving peak performance. International patient safety goals are one of the very important guidelines to give a safe service to the patient. Identify the patients correctly as we go through the goals one by one. Identify the patient correctly. We are using the patient's full name and the MRN. So we are identifying the patients correctly to protect the patient as well as the healthcare worker. Patients are identified using two identifiers, not including the use of the patient's room number or location. Patients are identified before providing treatment and procedure. Patients are identified before any diagnostic procedure. The second important goal is improve effective communication. The organization develops and implements a process to improve the effectiveness of verbal or telephonic communication among caregivers. So the organization develops and implements a process for handover communication. The organization develops and implements a process for reporting critical results of diagnostic tests. Third important goal is improve safety of high alert medications. The organization develops and implements a process to improve the safety of high alert medication. The organization implements the process to manage the safe use of concentrated electrolytes. We already know that there is a policy, safe medication. Under the policy, we know we already have the guidelines how we need to take care of high alert medication. How about the administration, the storage, and the transportation and everything related to it? And the fourth IPSG goal is correct site, correct procedure, correct patient. So the organization develops and implements a process for ensuring correct site, correct procedure, and correct patient surgery. So we have timeout already. We have a timeout form in the Salama. The organization develops implement the process of timeout that is performed in the operating theater prior to the start of surgery to ensure correct site, correct procedure, and correct patient surgery. And it is also used in the invasive procedures. IPSG goal 5 reduce risk of healthcare associated infections. So we have 5 moments of hand hygiene. So before touching the patient, before cleaning, before the clean and aseptic procedures, and after body fluids exposure of risk, and after touching a patient, and after touching patient and his surroundings. So hand hygiene is very important. Fifth goal is reduce harm resulting from patient fall. So screen, assess, and intervene. That is why we have a fall risk. We are doing fall risk assessment for pediatric as well as adult patient, and we are having a high risk. If patients are having a high risk for fall, we are notifying the physician as well as the treating team, and we are periodic assessment we are doing. We also maintain a KPI for fall risk. What are the challenges? Barriers to patient safety culture, complexity, lack of leadership guidance, lack of clear measures, persistent fear, multi layered hierarchical authority, diffuse accountability. So, these are some of the barriers for patient safety. Culture assessment reports pains, teamwork within units, punitive response to errors, underreporting, fear of retaliation. So whenever there is any incident, that is why we have to report the incident. Incident reports are not to punish the person or not to blame the person, but incident reports are always to improve our workflow, improve the patient safety, and implement new strategies in case of we need to modify our daily care to the patient, or we need to take more measures how we can protect our patients from having any kind of harm. Thank you so much for your patient listening. Have a good day.